welcome to Community Matters, a podcast from the Canadian Association of Community Health Centres. I'm your host, Hilary Leblanc. On this episode of the podcast, I'm speaking with Naini Cloutier, Executive Director at Somerset West Community Health Centre, and Michelle Hurtubise, Executive Director at Centretown Community Health Centre, where we are located today for our first in-person podcast, as you can obviously tell. Thank you both for being here. Both community health centres are based in Ottawa, Ontario. Both Centretown Community Health Centre and Somerset West Community Health Centre provide a wide range of health and social services geared to the diverse needs of individuals, families, and groups in Ottawa. How are you both doing today?
Excellent, great. Happy to be here in person.
I'm very excited. This is a new endeavor for us.
And I will just say for the audience, I just want to start that I do actually have a service dog and training in the room. And so if you see me looking off and scattered, that's what it is.
We have a puppy. We have a catch puppy. We joke about
catch puppy. Yeah.
We joke about cats being the mascot, but today it's a puppy. So I'll start off first by asking the two of you to tell me a little bit more about your community health centers, some of the main aspects of your organizations, the communities that you serve, and the services and programs that you provide. Michelle, if you want to go first.
Sure. Well, we are being hosted here at Centretown Community Health Centre. So it's in downtown Ottawa, sort of Banking Cooper for people who are familiar with Ottawa. We were in the red zone during the convoy occupation. So we were locked down for our services. We were still delivering services, but we had our doors locked to protect staff and clients. But like most community health centers, provide a broad range of health and social services. We have been one of the social prescribing pilot projects that are being hosted across Canada. And some of our priority populations are seniors, 2S LGBTQ, particularly newcomers, and particularly 2S LGBTQ newcomers. And we also have an urban outreach program for people who are street involved and with mental health and addictions. We do a lot of harm reduction work, actually, in partnership with my colleague right beside me at Somerset West. So, yeah.
Awesome. And Naini, if you want to continue, and I will point out as well, we have had the privilege of interviewing a colleague of yours from Somerset West before as well. So if anyone is looking on YouTube and wants to search the playlist, we do have a previous episode, but for anyone who might not be familiar, tell them all about Somerset West.
Thank you so much. It's such a pleasure to be here in person. Somerset West Community Health Centre just celebrated its 50th anniversary.
Yay!
Yay. So, and it has been for these years in the Chinatown area, and has been providing many different services over all these years. We had the opportunity to celebrate all the accomplishments. And I guess I would say that especially with the pandemic having gone by, that one of the biggest impact we are seeing in the community is around mental health.
Mm-hmm.
So Somerset West has a lot of services that we provide in collaboration with many agencies. And in particular, we have been focusing on the Black, Chinese, Vietnamese, Cambodian, and a lot of work has been done in outreaching into the community as well. We just recently had profiled, I think the citizen profiled our outreach work in the Black community. The other, our neighborhood has a lot of, dealing with a lot of different crises right now, the opioid crisis, homelessness, and a housing crisis.
Yes.
So we have an advocacy committee. We work very closely with Centretown Community Health Centre, and the areas that we have really done a lot of work with respect to that is harm reduction. And so we have a consumption treatment services, we have safe supply, and a lot of outreach services in the community, such as the drug overdose prevention education program, again, with our CHCs in the area, and also done a lot of work in rooming houses, where we send outreach teams, again, in partnership and collaboration. One of the things you'll hear a lot about is partnership and collaboration. We are very lucky to have some great relationships in the center, among the centers. And the other program I would like to emphasize, two programs are also regional programs. One is the Newcomer Health Center. And as you know, that We've had a global crisis in refugees are facing, and we've been doing a lot of initial medical assessments and wraparound supports. And it's a very difficult time in terms of access to primary care for these programs, and also providing lung health, complex pulmonary care support to people also living at home. I could go on and on, but I think I'm going to say.
I'm like, you're making me think about, oh, and I didn't talk about the diabetes program, and I didn't talk about Cancer Connect. There's lots of, like many of the CHCs, their programs go on, and yeah.
Which is amazing. And you guys are doing amazing work, which is why I am here to highlight some of it. And you mentioned, of course, so the collaboration, which is so important. And we had the pleasure of meeting at the Action Now conference done by the Alliance. And Michelle mentioned to me briefly the work that you guys were doing around some police abolition advocacy. And so that's what we're going to be talking about today. So from my understanding, Centretown CHC and Somerset West CHC have come together with several other organizations, including some other catch members, Southeast Ottawa Community Health Centre, Pinecrest Queensway Community Health Centre, Sandy Hill Community Health Centre, Carlington Community Health Centre, to all work on a document that you guys released entitled Rethinking Community Safety in Ottawa. I was wondering if you could tell our listeners what preceded this document and why it was created, as well as how this group of organizations decided to collaborate. And I believe, Naini, you were there from the beginning, correct?
Absolutely. And as you all know, in Ottawa, we have a wonderful coalition of community health and resource centers, of which the community health centers are part of. So this has been a coalition that has been in existence for about 20 years.
Yeah.
And through that process and looking at what was happening on the ground around the need for community safety and the very difficult situation of the justice system being involved, incarceration, and inadequate and inappropriate responses for the community that is the most marginalized. Group of service providers came together and started looking at what are some ways that we can plan to have a more appropriate and relevant response. And I think for us, something that we've been struggling, and I'm sure it's not just in Ottawa, is that the social services have not kept pace with the needs in the community, the complexity and the growth in population. And we know that even though there are these challenges, there are a lot of opportunities in terms of addressing community safety. So when all these different organizations came together, I think, and it was not just the community health and resource centers, there were other organizations that were around the table as well that serve diverse populations. We felt that there were ways in which we could scale up the existing programs. There were a lot of programs that we felt were on the ground that could more adequately respond to the issues of community safety and not be traumatizing in the process. And I think as community health centers, we are very connected to our communities. We are work closely with our marginalized populations. And we know that there are many, many programs where prevention and wraparound supports are the way to go versus a police response, which just further traumatizes people. And the other element that I would like to highlight is that as community health centers, we work in partnership. And we also recognize that we are only one voice or one solution in the array of services that are possible. And we certainly recognize the grassroots groups and the groups that are most impacted, the racialized communities, to be able to come up with and be part of the solution. So wanted to emphasize that we were just one voice that was speaking out about the need for better response.
I think Naini's given a good overview. I think there's so much we could talk about the details and sort of the next steps and recommendations, which She sets up beautifully
Yes.
for a follow-up question.
Yes, of course. My next question, and I have the distinct pleasure of reading the document, and of course, I'm very much in agreement with the document. So in an overview of it, some of the findings that you guys indicated that the police have disproportionately approached racialized groups, as you've just mentioned, during street checks and traffic stops, and that despite these findings, the City of Ottawa continues to raise investment in the OPS, the Ottawa Police Service, despite the existence of some other more effective approaches that you do list in the report. What other major findings did the report bring to light, Michelle?
Well, so I think one of the things is reinforced is that police are responding to things that they're not best trained to do. So there is a significant percentage of responses that are actually mental health and people in distress on the street. So just, down the corner from me, one day I went out for coffee and there were like 6 police officers responding to 2 individuals who were clearly in distress with an overdose. That's not necessarily a police response. It certainly may be a paramedic response, but prior to that, even with them being on the street, may have been called, is that the best response to that is some of our street outreach workers. Connecting with them, making sure that they're connected to services. A lot of interactions that people end up having with the police on the street is because somebody else, as I'm sure in that instance, called the police to respond to something. And all the police did in that instance, I watched there in the coffee shop, the police roused them from where they were and they moved along to someplace else, right? Which is also not safe. Because people, they may have actually been in a stage of overdose. It actually may have been more appropriate to get them connected with healthcare. So that was sort of primary, our call related to that. We knew from researching in terms of other programs that there are other supports and services that a high percentage of them, of those calls, are things that are like assistance with housing, people who are unhoused, individuals who are perhaps exhibiting behavior that is disruptive to a community. Again, that's not a police response. We don't need to criminalize that. But if you had outreach workers who could engage, if we actually had activities that were structured in the community that people could participate in, you wouldn't necessarily have some of those behaviors happening where neighbors are calling police on kids playing in the park or socializing around, quite honestly, or some for other situations around drug use. So different interventions and those appropriate interventions can avoid us criminalizing behavior that's just about engaging in community.
100%. Did you have anything you wanted to add, Naini?
I think the main thing also for us, the Rethinking Community Safety report highlighted that there are more less costly and more effective ways of providing services. So it is far more effective. Michelle made me think of an example in our community where a person was called, was in distress, and the police was called. And when they arrived on the scene, they didn't really know what to do, but one of our workers was just doing some outreach, and they went to this person and they realized that and they said to the police officer, pardon me. So we said to the police officer that what we can do is just take this person to sorry about that. We can take this person to their, to the center and provide them with some warm socks and give them some tea and give them a warm hug. And that's what the person needed at that moment. So I think for people who are living their lives in public, there are so many reasons why they are in the situation that they are. What they need is supports in so many other ways.
I will say, having just celebrated my 1-year anniversary with Catch, what you're describing is the thing that I highlight the most in this podcast, which is the wraparound care approach. And unfortunately, that is something that the police cannot provide with what they have. Of course, you can't, they're not out there with tea and socks and hugs.
And that's actually not what their intention, that's not what they're there to do. And yet in the absence of having a number that somebody can call, or lack of having a connection, that the only option that people have when they don't know where else to call right now is 911. And if 911 is only connected to police and paramedic services, as an example, or fire,
Sure.
someone who's in distress, now we've criminalized their behavior.
Absolutely.
And if it's not criminalized, we've certainly escalated the tension around it.
Yes.
And for populations, for individuals, as you know, I know you've we talked about in the report, for those who are from racialized communities, African, Caribbean, Black, Indigenous, people with mental health, people who are gender diverse, their interactions with police actually often result in harm to them. Their behaviors are seen as much more disruptive than if somebody who was non-racialized was behaving in the same manner. And so greater use of force tends to happen. So while we've talked about in the report about the cost that we can save the rest of the system in terms of reducing police interactions, we're also really interested in reducing the amount of harm that has been created by police interactions.
Absolutely. And as a racialized person, I can immediately say that there's just there is unfortunately an inherent like distrust and tension that exists regardless of being potentially criminalized for something that might just be a wellness check or anything like that. So I completely empathize with those people and understand that situation. And all of this really does set me up for the next question, which is, now that our listeners have sort of heard a bit about the report and about the work that both of your community health centers as well as the other ones do, in case it isn't clear, how does this over-policing directly impact your community health centers and the communities that encompass your clients?
What a great question. And so what the impact that it does have is that then there is, when there is that greater interaction with police, there is greater risk of incarceration, as an example. And so then once people get incarcerated, put in jail, that disrupts their housing situation. We're back to ground zero on it. It disrupts their health care. I mean, and although for some people it may be getting incarcerated, it actually may be the first time that they're actually getting access to care. But for most people and all the clients that we have that are connected with us, it disrupts that relationship, interferes with their treatment, their supports, but also their sense of well-being. But then when people are released, that housing and that cycle of homelessness, that cycle of it doesn't really matter what I do, so I'm going to act in the ways that meet my needs, and then again further perpetrates within that system of interactions with police, because police keep getting called. So one of the things for us is that when we're looking at this, and it's the whole system cost. So when we talk about there not being enough money in the system, often when they're saying is, well, we can't afford these things. The reality is that if we have different supports, we can actually reduce the amount of arrests. We can reduce, so example, the study in a report in Toronto, that when there's a full range of supports, there was a 56% reduction in arrests, a 68% reduction in incarcerations, and about a 40% reduction in ambulance and emergency room use. And if you think that each of those interactions with the police, with incarceration, with the hospital costs thousands and tens of thousands of dollars when you kind of spread that out.
Yes.
If we were actually putting that into community supports and services, into housing supports, into outreach workers, into harm reduction, into mental health supports, into substance treatment supports and programs, all of those things would dramatically be more beneficial, not just for the whole system, but for people themselves in terms of being able to perhaps find, I won't say it in terms of like a better life, that's not what I'm saying, but actually a better sense of health and well-being and sense of connectedness, because their life isn't getting disrupted and harm isn't happening. Like there is, again, I keep coming back to some of the real and physical harm that happens when people are having interactions with police.
And I just wanted to emphasize what Michelle made a very important point is it's really difficult for people who have been harmed to have a trust relationship, and having enforcement approach to problems that are really social in nature. You know, these are problems, as Michelle pointed out, you know, around homelessness, around living their lives in public. So if you don't have a washroom, you have to go wherever you can, or if you are using drugs or trespassing, public intoxication, all of those things really are not the purview of an enforcement model. And it prevents people from actually accessing services. So we know at our own site, if there is for example, even a police car parked outside, people will not come to our consumption treatment services or Safe Supply. There's been a whole history of trauma, and the same thing for the racialized communities. So when, as Michelle was pointing out, when you've experienced harm in the system, who are you going to reach out for support? So instead, we have amazing services in our communities, such as the Britannia Woods Community House, the Black Mental Health Coalition, like organizations that are led by the community that we partner with and have tremendous outcomes in terms of scaling up. You know, a mobile van, for example, that goes and supports people is going to be so much more effective than enforcement.
100%. So Naini, I'll ask you, what has the response been to this document so far within the community from the OPS and other government officials, and have any changes been made since the document was released this past December?
Absolutely. As I said, we were just one voice among many voices who were asking for changes. And when the community rises up to address and call out on how the system can be better, it does bring about change.
Okay.
And in this respect, the council voted for reducing the police budget by about 1%, so that a larger percentage of the new city spending could go towards social services. So that was a real win in the respect. Of course, this is a very small amount, and the need is so much more. There were for this little amount of funding, there was something like I think I won't be exaggerating, something like 90 proposals.
There was 90 proposals, and something like it came to like over close to $9 million in requests.
And exactly, and so these are for alternate responses for community in crisis. Also, the city has now a guiding council, which is a cross-sectoral committee to look at alternate responses to crises. So that is also in the work. But again, all of this came because of the entire community and those with lived experience speaking out.
Yes.
Huge amount of activism to get that. You know, and I think, well, there was certainly calls to significantly reduce the police budget. I think it's really significant. It's probably the first time in the whole police services budget that it was even reduced from the original ask that they asked for. It received unanimous support by the police services board. Like, police service board members actually told the chief to come back with a revised budget. I don't think that's ever happened. And, you know, city council was also in support. It wasn't unanimous because there was other people who were actually, the people who voted against was like that there needed to be more money for social supports and services. And so a huge amount of work went into that within the community to achieve even that small success.
That's amazing.
And as community health centers, we made a number of deputations, including our organizations that we went to the city council.
Okay, amazing. What further changes are you looking for after that small success from the City of Ottawa and government officials? And furthermore, the document's called Rethinking Community Safety. What do you think safety does look like for the City of Ottawa, Michelle?
Well, I think that's a great question. And one of the things that, Naini sits as a representative of the Coalition of Community Health Centers, along with one of our colleagues from a community resource center on what's called a guiding council that is been brought forward to implement the City of Ottawa's safety and well-being plan, which is a requirement in Ontario for every city to develop a safety and well-being plan. And so one of the things that we're focusing on is trying to say that that little pot of money of that 2.1 million that went and had a sprinkling of projects, really important grassroots, is only a starting point. And one of the things that we need to really do is focus on that 40% of calls that police receive that are not violent, are not criminal in nature, but are really for social issues, and develop that fourth, I think we're calling it the fourth way, or the community is calling it the fourth way, but a response that doesn't actually involve the police. So we're really advocating for, there are some models and there are some people in our community that are calling for co-responder models, where actually the research has shown that those are not effective.
Right.
We actually want to leverage a system where people can call, whether it's 911 or another number, but that have a number that they can call and somebody else responds when there is a crisis. So that because we believe those alternatives, again, whereas Naini has given a couple of examples where it really is about, can we get them to a warm bed?
Yes.
Can we get them a hug? Can we get them a meal? Can we actually get them some support if they're having a reaction to a drug overdose?
Right.
And it may actually not be necessarily where they're having a drug overdose where they actually need to be medically supported at a hospital, but just having somebody with them until they're coming kind of out the other end is that real response. Having community supports and resources, as we've said, in community programming. So one of the pieces that happens, particularly with young people in encounters with police, and particularly young racialized people, is just gathering. So ensuring that we're actually having the supports to help people gather and not actually have police called on them would be some of those kinds of community responses that we're looking for. And really a different model of who you can call when it is 1 a.m. and there's something happening in your community.
Yes. Did you have anything else that you wanted to add to what you think safety would look like?
I think it is really critical not just to think of the crisis response, but also to look at the prevention element. An example of the prevention programs are the homework clubs, the youth groups that happen, and there is not adequate funding for these programs. And it always surprises me why there's tons of support for at the other end when there's a crisis. For incarceration, which is so much more expensive, but there's nothing at the prevention end to support the community. So I think I would like to give the example also of DOPE, the Drug Overdose Prevention Education Program, in which workers in collaboration with Centretown and the Carlington Community Health Centers go out and proactively prevent overdoses and work with the communities and look at what kind of wraparound supports people who are precariously housed or are homeless need, which is a very different approach than a person being in crisis. And they provide education about all the different supports that are needed. So it's a different way of approaching things. It's a different way of approaching when you have youth programs where you develop leadership programs versus looking at when the crisis. So I think that's what, as community health centers, our focus has been, not just the crisis, but the prevention, the community development work that is so critical, in addition to all the other services, primary healthcare, counseling, and all the other services in the community.
And I think one of the things, when we were actually doing our deputations, like this was a couple of years ago, but one of the examples for one of our colleagues in the Community Resource Center is the spin-off, or the way that it evolved in terms of actually not getting funding for some summer programming meant that they couldn't hire summer lifeguards, which is a youth employment program, which is about a youth engagement strategy. which then meant there wasn't access for younger kids to the services, but there also wasn't employment happening in the
Right.
community. And without employment and without those engagement activities, then people are also ripe for other kinds of engagement activities and gang activities. As an example, gangs are great at building a sense of community and belonging.
Absolutely.
And a way, particularly in communities that don't have easy access to employment, to earn money through those kinds. So being able to have, youth employment programs, recreational programs that employ youth from the community are designed by and for and with the community, have huge amounts of impact. And then we don't actually even see the interaction with the police where somebody has to call. And, so there's lots of those examples in community health services and social services across the country, but they need to be resourced.
Absolutely.
And the other thing I would add is there's a huge issue around access to mental health services.
Yeah.
Yes.
Not because there are not enough mental health services, but it's because there are not culturally centered mental health services. And I think that is one of the areas that we have been working very hard on. For example, we have had outreach and conversations during the pandemic around access to mental health.
Yeah.
And for a lot of the communities, especially the ACB community, it has been difficult to access because they do not feel that the services that are on the ground actually respond to their needs. And they've actually been traumatized
By
through the
trying
system,
to access services.
and through when they do access by people not being able to support them, or they've been traumatized through the system. So I think that is where also we feel that there needs to be a system-wide change, and we all need to be part of that change. As organization, we need to look at our own organizations as well, and the organizations that are in the system, how they need to be changed as well.
And so part of that work that we have been doing as part of the coalition as well is trying to increase access, for example, to those mental health supports. It relates to another, project that we're both a part of Counseling Connect, but ensuring that there's additional access. And what's great about that initiative is that people can specifically request a 2S LGBTQ counselor. I can specifically request a counselor from the ACB community, can specifically request an Indigenous counselor, can specifically request something from the Muslim community. So really have that effort of access, and as Naini said, trying to destigmatize, but also to create a different experience. I think it's not just only that people feel that it's not there for them. In fact, they have experience that it hasn't been there for them.
Absolutely.
And that real harm has been created. And so trying to increase the access with those services, again, by and for the community, is a critical prevention part.
Absolutely. There were so many great nuggets in that whole little spiel, but what I noticed in the document that surprised me, and you highlighted again here in person, was I've heard so many people say that just pair a mental health worker, a caseworker with a police officer, and that'll be fine. And to see like the concrete evidence that no, in fact, it is not. I found that like very, very interesting.
And the research shows that it doesn't, because what happens as soon as the police officer shows up is it doesn't actually de-escalate the situation. It ramps it up.
Yes.
Not just because people have had past traumatic experiences with police, they have. But, I'm just going to say a name. As a middle-class white woman, when I see a police car behind me and I know that I'm still following the rules of the road, I get anxious.
Yes.
I am wondering what's going to happen. And I am not particularly targeted by police for any of my driving behavior or just even walking and existing on the street,
yes.
Right? So if that's the case for me, just an acknowledgement that imagine that multiplied for people who have had negative adverse effects by police.
Absolutely.
So it even though sometimes in the police conversation, what they will say is, well, we know we need to come in case we actually need to escalate. That's the wrong response. The right response is really that there is a non-police presence first. And then if it ends up being, then we can call in the police. But in fact, the models that are non-co-respondent models have actually demonstrated, and I can't remember what the stats are, but there's actually a very low percentage of calls that they respond to that they actually have to transfer to the police. So the evidence doesn't bear it out.
100%. I had found that so surprising, but it does make perfect sense. And so anyone who was maybe like clicked on this and didn't know enough about community health centers, or even me a year ago before having this role, might have been surprised at seeing community health centers like championing this kind of change and being one of the many voices in this conversation. What do you think your respective experiences around the research and disseminating this document while still operating your regular community health center programs say about the ability for community health centers to adapt to emerging social and public health issues and the importance of CHCs within our health and social service systems?
So one of the things that I love about CHCs is, in fact, I think for virtually all of us, the emphasis on equity as well as prevention. And to me, that deeply goes into why we would be involved in this work. And because as community health centers, quite honestly, we are often serving people that nobody else wants to serve. Naini and I have referenced a couple of times the work that we both do, as well as a number of our other colleagues in the city, around people with significant mental health and substance use. They can be really challenging to serve. They're challenging for us. We also know that the way forward in terms of serving them and supporting them is providing that access to meal, food, shelter, clothes, a hug, a shower, a washroom. That's all part of the prevention and wraparound type services.
Yes.
So when you look at it from that perspective, it makes absolute sense that we would be part of this conversation and dialogue about having a different response. In addition, we've always been concerned as community health centers, and one of the things I say to people about what I really appreciate is that even though we're listed as one of those models of primary care, we have never just been concerned about someone's individual health.
Yes.
We are concerned about the health and well-being of our community, of our neighbors. And as a result, we actually want really good, strong, healthy communities. And part of that means having different kinds of responses and supports up front. And so for me, it's just natural that we would be part of this discussion.
And I think, Michelle, you said it so well. I think as community health centers, we want to create a healthy community where everyone feels that they belong. It has to be, it's not about individual programs. It has to be where we look at what the root causes are. We look at, as Michelle has described, what are ways that we can create a healthy community. So for me and all the other people who are working in the CHC world, it's really a movement. It's not, we are not just deliverers of service. We are part of a movement to create change. And when you create change, we also know we cannot do it alone. We have to work with partners. We have to work with people who are most impacted, people who have lived experience, for example. And how do we, we are looking at ways of, and we've always done this, and we need to work even more closely with people who have been impacted. We have people with lived experience who are delivering services, and also work with networks and organizations that bring different partners together. So, CHCs, we have a duty, and we are part of organizations, groups like the Ottawa Local Immigration Partnership. So in Ottawa, we have a wonderful LIP that has done extensive work in addressing so many different determinants and planning in the city to be more welcoming to newcomers. So as CHCs, I think it is critical that we be part of these networks and we build a momentum with our partners to create change. So
Mhm.
to me, that's what embodies CHCs.
100%. I'm happy to be part of the movement and to educate everybody about this. I think it's such an important topic. If anyone wanted to learn more about Centretown, our lovely host, where would they find that information?
So you can look us up on the internet. Our website is quite simply centretownchc.org. If you're interested in the whole coalition of community health and resource centers, we also have a website where this document of Rethinking Community Safety is, but also on some of our other advocacy initiatives.
Of course. And for Somerset West, if anyone wanted to learn more about your community health center, where would they look?
Again, you can just Google Somerset West Community Health Center, and you can go to our site. We have all our reports, different kind of reports, and there are linkages that you will be able to get access to. And you can also call us. You can call our numbers. They're all on the site, and we have an info line on that. It's an interactive website, so you can certainly connect there, and happy to speak to anyone who's interested.
Perfect. Michelle, Naini, I want to thank you both so much for your time today and for hosting us and having my first in-person episode of Community Matters.
Thank you so much, Hillary. I'm delighted to have you here in Ottawa and at Centretown, and for everyone's patience as I attended to puppy.
That's okay.
So,
Thank you.
Thank
We
you.
really appreciate the effort you've made to talk on this very important topic. Thank you.
Thank you.
Thank you.
Thank you for listening to Community Matters, a podcast from the Canadian Association of Community Health Centres. To learn more about our association and the important work of community health centres across Canada, go to www.cachc.ca.